The last night that she's
Right. We're going to get our afternoon program started. We'll get everyone just to settle down in here, and hopefully you can hear us online again. Welcome back. Hope everyone had a nice lunch and a nice opportunity to network. I certainly got to meet a lot of faces I hadn't met in a while, so that was nice. We're going to have Dr. Narang present her talk. We did the formal introductions this morning, so I'll just share an anecdote that she's taught me everything I know about sleep and sleep medicine. So I'm sure she'll be able to teach you as well a lot with her interesting talk. So I'll hand it over to you, Dr. Narang.
Thank you so much. I think you also taught me things, Kevin. So all of these teaching is definitely bi-directional. Thank you for the invitation to talk. And I will just get started by trying to move the slides.
Can you give it a hand?
Okay, have no conflicts of interest. Today a little bit, I'm going to talk about the different phenotypes and how they may apply to obstructive sleep apnea. But what I really want to focus on today is about different management options for children. And I really want us to think beyond our traditional therapeutics, such as adenotonsillectomy and CPAP. Just before I get started, I always like to know who my audience is. I don't know if I'm able to see any messages online, but maybe I'll ask the in-person audience here. How many of you here are sleep technologists? Raise your hand. Okay, quite a lot of you. I've always learned a lot from sleep technologists. I was always very grateful that nobody ever asked me to score because I was really bad at it. Okay, how many of you here are adult physicians? Okay, a few adult doctors. Okay, I can't see the responses from online right now, though. And how many of you here are pediatric? Okay, a couple of people. How many here are respiratory therapists? Ah, great. And psychiatrists? Yeah, psychiatrists. Okay, who have I missed? Raise your hand and tell me what you do. I missed somebody. Okay. Okay, looks like I've covered everybody. Okay, it's always helpful for me as I go through this, but I think the really great thing about being in sleep medicine and practicing sleep medicine is that anything I'm going to talk about today, including the work that I've done, is an entire team effort. So none of us are working independently. And certainly my journey in sleep medicine has not been a solo journey. It's been a team effort. I just want to have a shout out to one person here, Jeremy Gibbons. Hands up. So Jeremy Gibbons was the person I worked the most with when I started my sleep medicine journey at Sick Kids, and you taught me so much. Jeremy's just retired from Sick Kids after what I would say is an incredible journey. I'm just going to take this moment. Please could you all give a round of applause for Jeremy. Okay, so I know you've heard all of this before, but because I really wanted to frame my talk, I'm just going to go through some of the basics again. So just bear with me again, because I also think that, you know, repetition is good. It's always important for us to keep consolidating what we've learned, but also how I understand pediatric obstructive sleep apnea. So I think we all understand what the definition is, and that it basically occurs, or how I was taught, in 1 to 5% of all children, with the most cardinal symptom being nighttime snoring. And that, of course, our gold standard is polysomnography. We can debate the benefits of polysomnography. So even though it's called the gold standard, I think many of us agree that there are other standards that we should be considering. We know the commonest etiology in children is big adenoids, big tonsils, and of course an adenotonsillectomy is curative in the majority of otherwise healthy children. And we also know about the burden of OSA, but we're really learning so much more about the burden of OSA. So in childhood, we know it's related to poorer academic performance, adverse neurocognition, especially neurobehavioral issues, downstream, especially in the context of obesity. It's associated with cardiometabolic disease, as well as we're learning much, much more about mental health and the increased risk of anxiety and depression. And there's also a large amount of data now coming out of Europe saying that if you have childhood OSA, especially if it's untreated, in adulthood, you have an increased risk for healthcare utilization. You're less likely to be in full-time employment. You're more likely to be accessing social support. And so that's really important because that really equates to long-term significant socioeconomic impact of children as they go into adulthood. I'm not going to just talk much about that, but I think really emphasizing the importance of treating obstructive sleep apnea in childhood. Okay, so here's the real story I want to talk about. I told you it all sounds great. You bring in a child diagnosed with obstructive sleep apnea, they have an tonsillectomy, child's happy, mom's happy, everything's cured. But in fact, that is not the real story and what we're seeing now. We know that even though 2 to 5% of all healthy children will have obstructive sleep apnea, it's much, much higher in children with complex comorbidities. And now with the advent of advances in technology, there are many, many more children with complex comorbidities actually surviving to adulthood and beyond. And I would say the majority of those have obstructive sleep apnea. And if you just take one example, children with Down syndrome, the prevalence is anywhere between 80 to 100%. They have even worse neurocognition, plus their baseline tends to be lower. So the burden of OSA is much greater in those. And importantly, adenotonsillectomy is not curative in the majority of those kids. So they have CPAP. And you know what? CPAP works. Adult doctors will always tell me CPAP works. There's even good pediatric data to show that it works, but CPAP doesn't work if you don't wear it. And that is the biggest challenge in pediatrics. And so I think you'll probably all appreciate that there really is an urgent need for not just surgical, but also non-surgical, easy to use, alternative, and comfortable therapeutics. I just want to talk a little bit about CPAP. So we use the adult definition for adherence. And as I've said, that, CPAP only works if you wear it. And in this study done by Rakesh Bhattacharjee, who actually also trained the sick kids, in this data with 20,000 children from the US, they found that 43% used CPAP for at least 4 hours for 70% of the nights during a consecutive 30-day period. And as you can imagine, the major barriers are similar to adults. They don't like the mask, they feel claustrophobic. And then we forget about the caregiver burden and stress. I had a family in my clinic just a month ago. The kid had incredible adherence, 100% adherence. I was patting the child on the back, saying, hey, you need to come into my clinic and teach the other kids. And the mother said to me, you see this perfect adherence? And I said, yes, it's amazing. She said, you don't know the 2 hours it takes me every single night to get this kid to wear the CPAP. It's a real issue in our family, at bedtime every night. And I guess we don't always appreciate the caregiver burden. We see this adherence and we go, you're doing really great. I'll give you a pat on the back. So anyway, I think we just have to bear that in mind. But I'm just going to ask the audience something here. What do we think about this definition of adherence? Okay, so another mic. I'm just going to pick on somebody. Rahul. If you've got somebody you'd like me to pick on, let me know. I'll do that as well.
I think it's less ideal in pediatric patients where they're probably sleeping more, and so 4 hours is probably not a reasonable expectation of what you think compliance should be for those kids, and they have different sleep patterns. So I think that there's no standard definition, I think, for adherence in pediatric patients, but it's not ideal to be using the adult one.
Yeah. So that's great. But also, this definition says 70% of the night. Well, guess what? Children sleep every night, not just 70% of the night. So we adopted this adult definition. It should never be applied to children. And so we have really talked about adopting a different definition, which is using CPAP 6 hours for every night. And even 6 hours is low for the majority of children. So we decided to look at our data and say, what happens when we use the 6 hour definition? So this is unpublished data from sick kids. And here you can see when we use the definition of the 4 hours, 70%, you can see how many adherent. But when we apply a 6 hour definition, only 22% of our children are adherent, which is really showing that CPAP use is subtherapeutic. We cannot expect that we're going to improve childhood outcomes with CPAP. There has to be other alternatives. And here's another study that was done by my master's student, Sarah Salvatore. And what we showed is that the kids that were wearing CPAP and were transitioned to adulthood. And so these you can see here, like 5 hours and, a decent amount of PAP usage. Here's what happened at 12 months. At 12 months, the average PAP usage was 2.6 hours a night. And we don't know why that happens. What we know is that we spend millions of dollars really helping children adhere to CPAP. Within 12 months of transitioning to adults, they fall off, they stop using it. And when we asked some of our adults, like, hey, what happened? We actually did a qualitative study, and this was part of the transition program I do with Toronto General. When we asked them, one of them, I'll share a funny anecdote. He's like, you discharged me, so I didn't think I needed to wear CPAP anymore. But they didn't like it. It didn't fit in with their adult life. They were going to university. So there's many, many reasons. But again, showing that there's a big fall off in adulthood. So what did we learn from this? We learned so much, and this is a whole host of research done at the sick kids. Is kids don't like CPAP, parents don't like CPAP, and that actually a one-size-fits-all approach doesn't really work for OSA. So for those children that don't wear CPAP, that require CPAP, we have to think of what else can we offer them other than CPAP. So I want to talk a little bit about the endotypes and why they may become important. So a lot of this data is actually from adult literature here. And we know that the majority of the kids that we will see have a real anatomical phenotype. So adenotonsil hypertrophy, pharyngeal fat, tongue volume, and of course, abdominal fat. As we know that an increased abdominal circumference decreases the tethering effect on the pharyngeal airway, predisposing to upper airway collapsibility. But we also know that this is evident in our children. It's a poor muscle responsiveness. And what this really means is that there are children who, with increasing negative pressures predisposing them to upper airway collapsibility, their muscles are not responding fast enough to dilate to prevent the upper airway collapsibility. So about 30% of children will have poor muscle responsiveness. We're also recognizing that the low arousal threshold here. So a low arousal threshold just means in response to increasing negative pressure or upper airway collapsibility, our patient child is arousing, and as they're arousing in the shifting sleep stages, that shift in sleep stages, it means that the muscles can't actively recruit and respond in the same way. So this transitioning through different sleep stages gives a lot of respiratory instability, also promoting upper airway responsiveness. And then high loop gain, again, I think probably the adults are more familiar with this, with these concepts, but high loop gain, so for very exquisite small changes in carbon dioxide, there's huge ventilatory changes and ventilatory instability. Oh, am I too close? I'm too close. Okay. I'm too close to the mic, so I was probably getting excited. So low arousal threshold and high loop gain. So respiratory instability, which I think also lends to changes, huge swings in your respiration and huge swings in your muscle responsiveness. So how can we use some of these data or some of these concepts to really think about what are some of the options for our children? So I want to come back to this, that we have anatomical variability, but we also have poor muscle responsiveness, which I think are the main factors in children. So we are proposing this approach here, and this paper was published by my group in the Lancet, and you can see here that we really need to identify the risk factors for OSA, persistent OSA after adenotonsillectomy or even before, obesity, neuromuscular, genetic, craniofacial causes. And I'm not really going to talk too much about the social determinants of health, but we do know that they play a huge role, probably through the pathway of inflammation in promoting upper airway collapsibility. That we have to take these risk factors into mind, look at all of the available and accessible therapies, and then use a shared decision-making approach here, and looking at the patient preferences to guide them to the right therapy for that patient. And when I say the right therapy for the patient in the context of children, it's for the child and the family. And so we have pharmacotherapy. I'm going to talk about all of these shortly. I've already talked about CPAP here, and I'm not going to talk much about that, but I will just talk about therapies beyond CPAP, so high flow therapy, positional devices, and then, of course, some of the really advanced surgical interventions to help guide some of these management issues. So let's just talk about, as I mentioned, just some of these approaches right now. I know Rahul has talked to you about heated high flow therapy. Rahul, did you cover all of this? Oh, you did. Okay. Well, I might do better because it's my study, but that doesn't really matter. But just in essence, to say that this was just a proof of concept, randomized controlled study in the sleep lab setting only, where no oxygen was applied, just to see if high flow could be as effective or non-inferior to CPAP. I'll go quickly through this because Rahul has covered it, but there was a lot of diversity of our patients, which really reflects the diversity of the patient population we serve at SickKids. And most of them were medically complex and or had obesity, and the majority of them had an adenotonsillectomy. And just to talk you through, Rahul, did you go through all of this? You did? Okay, so you know, I'm just going to jump here, that high flow was not inferior to CPAP, and all of the secondary outcomes that we were looking at in terms of oxygenation indices were similar to CPAP. And then what we really wanted to know, did you cover this? I found something I didn't cover. What we really wanted to know is actually, what are we hoping to improve? We're really hoping through high flow that can we really address the hypoxic burden that we know is associated with obstructive sleep apnea. And when we look at CPAP data and high flow data, we know that there were similar reductions in the hypoxic burden with high flow compared to CPAP, really telling us that this could be an effective alternative therapy for CPAP. And the advantage of high flow, as Rahul likely pointed out, is that it is really comfortable compared to CPAP. Have any of you tried high flow? Have you tried it? Actually feels really good. It's really warm. All this air goes through your nose, and it actually makes you feel quite sleepy, especially at lower inspiratory flow rates. Did you cover this, Rahul? Okay, and then what I wanted to point out is we don't actually know how high flow truly works to address obstructive sleep apnea. We all know that with CPAP, you need a positive distending airway pressure to keep that airway open in the context of upper airway collapsibility. But we know high flow will not deliver similar types of pressures. And in fact, when we look at CPAP pressures here compared to high flow, here you can see the children that needed CPAP pressures of 12 needed only a flow of 40. Similarly here, needed a flow of 60. And why is that important? So we know that 60 liters per minute is only equivalent to about 5 centimeters of PEEP or 6 centimeters of PEEP. So highlighting that we know it works to address OSA, but we probably don't know the entire underlying mechanisms of how it works.
So it actually improves the air flow into your nose and eventually into your brain. So it improves the oxygenation in your brain. So decrease the hypoxia and help you sleep and improve your cognition.
Okay, so for the online group, the question was like, do we think it improves oxygenation and flow? So we know that high flow has, like, you know which flow you're delivering, and it's very high in respiratory flow. This study was done in Ruma. It doesn't explain all of the mechanisms. What we think is happening is that the high flow is actually activating the mechanoreceptors in the nose, and the mechanoreceptors are promoting advantageous changes in the respiratory system. We think, but I still think there's a lot of work to be done about how high flow does really work in addressing OSA. And so right now we are undertaking a randomized control trial across Canada in children, so hoping to recruit around 300 children, whereby they're going to be randomized to CPAP versus high flow in the home setting for 3 months. And the goal here, actually, the primary outcome is adherence. And many people ask me, like, why are you interested in adherence? Because I have a therapy, I think it works, just like CPAP works. The question is this going to be the same story as CPAP, that we prescribe it, it goes in the home, and then people don't use it for whatever reason? So the actual primary outcome here is adherence. And the newer version of high flow, Evo 3, actually has inbuilt adherence mechanisms. So just like CPAP, we're going to be able to see observe the download data and be able to see who wears it, when they wear it, and how long they wear it for. So I will come back when I have those results, but I'm only at the start of this study. Okay, so when do I prescribe high flow? Rahul, did you cover this? Oh, he didn't cover this. So when am I prescribing high flow right now? I'm prescribing it. It is in the homes of children. When a child is CPAP intolerant, and even if it's being purchased and trialed in the homes, when the child is symptomatic, it's impacting both the child and the family. There's significant impairment in quality of life. And after I've done a PSG titration with high flow to show that high flow is effective in reducing the OHI. And right now, we've always prescribed it to families where they're either able to afford high flow or there's some mechanism of funding. But Ontario is just about to approve high flow similar to CPAP to be prescribed. So that hasn't happened yet, but I think it will really change the face of how we're treating sleep apnea in children. So I want to go on to positional therapy. So Rahul, did you talk about positional therapy? Okay. So I'm really interested in positional therapy because A, it's cheap, it's readily accessible, it's non-invasive, it's portable, it's scalable. And the one thing that I think it's really important as we think about therapies for children, it really addresses the disparities in both access and delivery of sleep health in children. So if you live 6 hours away, your chances of seeing a sleep specialist are pretty low. But what if there was a different mechanism by which we can do virtual visits? We're pretty convinced this is positional OSA, and we can prescribe a belt. And we can base our both indication for the belt and follow-up on symptoms and so forth. But there's very little data on positional therapy in children. So I'm gonna, the first study done in children was by Lena Zhao, who's now faculty at the University of BC. And she showed in this observational study, she took 10 children, she took their baseline data, and she put them back in the sleep lab with a positional belt. And this positional belt we used was called a remedy belt. And it's actually just like a little backpack with inflatable bumpers in the back. So it prevents you lying on your back. And what she did in this study is that she gave everybody one of these belts, and then she looked at their OHI before and after, as well as their sleep time and their oxygen desaturation index. And I think you can see here, some children definitely responded. All children decreased their supine sleep time, and group data didn't show that it improved the oxygen desaturation index. But this was being really driven by this outlier here. But I think if you focus on the other 9 patients here, there was a reduction in OHI. And similar here, reduction in the oxygenation index, saying that maybe there's a group of children who really respond to the positional belt.
Looks like a reverse bra.
Okay, the comment was, it looks like a reverse bra. Okay, I can't unsee that now, actually. Okay, so Lena went on actually to do a randomized control trial, similar to the high flow study. She did a baseline sleep study, and then she did a crossover trial where she randomized these children either to a control, and for the control, they still had the belt, but we didn't inflate it at the back. So it was just like a flat belt. And then the crossover part was where she inflated the belt so they couldn't lie on their back. And here the primary outcome was looking for a reduction in the OHI. And there was a whole host of secondary outcomes as well, but also we were interested in the comfort of the belt. So I'll take you through some of the data here. So I think you can see that there was a significant reduction. This is the percentage of total sleep time. Significant reduction here in the total sleep time. But look, some people's total sleep time with this positional belt actually is the same, or it went up. And then we think that really reflects the night-to-night variability in children that is missed often on the first night. Again, there's box plots just to show you significant reduction in the total sleep time. However, that did not play out when we looked at the OHI. Again, you can see here, and I'll just disentangle this for you. There's a few children that improved. Their OHI improved significantly here. Some, the OHI went up, and some didn't change here. And when we looked at the group data, it was not statistically significant. But when we really interrogated that data a little bit more, what we saw was that there was a group of children, maybe 7 or 8, actually, that had resolution of OSA. But we really want to identify which group of children did benefit. And it looked like those with a lower baseline OHI, those that actually had a much higher supine to non-supine OHI ratio. And interestingly, those with medical complexity seem to benefit more than otherwise healthy children. So one of the things that we're actually looking at right now is that we are endotyping. I've talked about the endotypes. So this group is actually having endotyping data done right now to see what was different about the responders versus the non-responders. So again, hopefully have that data actually in the next few weeks. We're almost there. But that will be important. But we're continuing to do a much, much larger randomized control trial also to help us look at the clinical phenotypes of the patients that are responders to the positional belt versus that don't. Okay, how many of you are familiar with drug-induced sleep endoscopy? Okay, at the front. Okay, so I'll just quickly talk you through this, which is that this is a nasal endoscopy performed in the OR, usually with something, an anesthetic called dexmedetomidine. And dexmedetomidine is thought to mimic sleep. And while they're under dexmedetomidine, the ENT surgeon will take a look and will actually be able to see the different sites of obstruction. So here, it just shows you here, you know, is it the adenoids? Is it the tongue base? Because we know tongue base is a major site of obstruction, especially in some of our children with medical complexity. And then in real time, the ENT surgeon not only can see the sites of obstruction, but actually can target those sites of obstruction for surgical intervention in that single procedure. Now, DICE was rolled out without any evidence. It was actually rolled out, thought to be effective, and now we're collecting the evidence in children. And there are many people, but really led by the US, who really believe that the first line of treatment should no longer just be a straightforward adenotonsillectomy, but it should be DICE, with DICE directing what surgery you're going to do the first time this kid goes to OR for the management of their OSA. And so I want to show you this study here. And like I said, there's very few really robust studies. I know there's a large randomized control trial going right now in the US, but I want to show you the outcome of this study, which we know we see a lot of children who are obese and overweight. And here, in this study, they took two groups of children who are obese and overweight, obese, and about half of them were surgically naive, and the other half had her prior adenotonsillectomy. And here you can see those that were surgically naive, yes, the majority of them still had an adenotonsillectomy, but actually only 50% had an adenotonsillectomy. The others had other surgeries, including a lingual tonsillectomy, a supraglotoplasty. Typically, these surgically naive children would have all gone for an adenotonsillectomy, so only half were deemed eligible for an adenotonsillectomy. And in those that had a prior adenotonsillectomy, you can see there's a whole range of surgical interventions that took place. So overall, they're able to show a reduction in the OHI, as well as an improvement in the oxygen nadir, so oxygenation indices improved. So there was a reduction in OHI, but still the reduction was greater in those that were surgically naive. So the randomized control trial that is going on in the US is going to address the question whether DICE should be a first-line procedure, because I think many people will agree it's an efficacious procedure. We do this at sick kids, but it is not routine or standard of care. I don't know, in the community here is anybody doing DICE? Okay,
A couple of adult ENTs.
Adult, yeah, I know. Yeah, and they'll see all the kids. Okay, and they'll see all the kids. Okay, that's good to know. So coming on to hypoglossal nerve stimulation, how many of you are familiar with hypoglossal nerve stimulation? I've got one hand at the back. Okay, all right. So I'll just quickly talk you through this. The main pharyngeal dilator muscle is the genioglossus, which is innervated by the hypoglossal nerve. So if you activate the hypoglossal nerve, it stimulates dilation. In this landmark study done, again, it was done in adults. They planted basically a pacemaker here, a wire into the hypoglossal nerve, and they actually activated that. So on inspiration, the muscle would contract and the tongue would protrude. I don't have a video, but I can tell you that I don't imagine that would be easy being a bed partner with somebody who's doing this all night. So, yeah, so highly invasive procedure, highly costly, but after 3 years, 2/3 of these adult patients had sustained benefits, not just in the reduction in AHI, but actually their daytime symptoms, particularly sleepiness, and documented much improved quality of life. And I remember looking at this and saying, well, this is never going to happen in children. I can't imagine that this would happen in children. And again, I was wrong, because this study came out in children with Down syndrome, where they actually, again, in 42 children with Down syndrome who had pretty resistant, I say resistant obstructive sleep apnea, they were not responding to CPAP. They had significant symptoms, significant impaired quality of life. And their data was exactly the same, actually, that after 12 months, that 2/3 of these children were said to be significant responders with significant improvement in symptoms and quality of life, both for the kids, but also for the family. Now, this isn't, as far as I'm aware, isn't available in Canada yet, but I know that the hope is to bring this to Canada. I do understand from the European market, it's incredibly costly and very resource intensive. You need really frequent follow-up, lots of polysomnograms and so forth. But I think for those that are really resistant to the current therapies, this really offers hope, especially to the Down syndrome population.
Just a question. So you mean periodic tongue protrusion?
Yeah, so as the nerve gets stimulated, the tongue, and that opens the airway.
Okay, so as you said before, oftentimes it's because the tongue fall back, obstructing the airflow, right? And that's part of the reason of sleep apnea. So I guess this hypoglossal nerve stimulation is to mitigate that problem. Yes. So the tongue is getting out of the way, and of course you sleep better.
Yeah, that was one of the mechanisms that opens up the airway. Yeah, for sure.
But then it may associate with more drooling, because if your mouth is open, your tongue stick out, then you drool.
Yeah, there was a bit of drooling, but actually the biggest side effect that they reported was actually numbness of the tongue.
And dryness.
Yeah, and dryness. So, are there any more questions, or otherwise I'll move on? Okay. So I really want to talk about novel therapeutics, because this is something I'm really excited about. The reason why I had talked about all of those different endotypes earlier on is so that you can see the drugs that are already available, but also coming on the market in really leaps and bounds to address all of the different endotypes of OSA. So here, drugs that will activate the pharyngeal dilator muscles. I'm going to talk a little bit about atoboxetine in a minute, potassium channel blockers, and so forth. So some of these are already being used in adults, and some of those are really part of a lot of trials at the moment. There's also drugs that we know that will increase the respiratory arousal threshold and therefore address loop gain. Address the arousal threshold issues such as trazodone. There's also a huge host of drugs now to reduce respiratory control, instability. So cetazolamide, but there's a recent data on sulfiam. Is anybody using any of these drugs in their practice? No. And then also, there's also drugs to improve your impaired anatomy and associated upper airway collapsibility, such as the GLP-1 agonist, and that's through weight loss mechanisms. So I'm just going to talk about a couple of these because I think they're really important. But we all know that if you can give somebody a pill, it's going to be way better than asking them to wear something every day at night. And many years ago, I had a family who said to me, like, we just need the magic pill, doctor. And I said, there isn't a magic pill. And but I actually think that there might be a magic pill now. So I'm going to talk you through this, which is, how many of you are familiar that the phase 3 trial data has just been released, and there's a couple of early trial data. Familiar? Yeah, you people are nodding. Fantastic.
Can you put that last slide back?
Okay, I'm just going back. Somebody will take a picture. Happy to share, by the way, this paper. It was written by Danny Eckhart from Australia. Interestingly, just so you know, I did my elective with Danny, my sabbatical. I did my sabbatical with Danny Eckhart in Australia, and he's really the endotype guru who has taught us a lot about endotypes. And actually, we are able to obtain endotyping data from PSG signal. So just to talk a little bit about oxybutynin. So oxybutynin blocks these receptors for acetylcholine on the hypoglossal motor neurons, and this makes the genioglottal muscle more responsive. If you remember, I said that poor responsiveness increases your chances of upper airway collapsibility. That's in REM sleep. Atomoxetine, and by the way, oxybutynin is an old drug for bladder control. So the great thing about these drugs I'm talking about, they're repurposing old drugs for the benefit of the management of OSA. So atomoxetine prevents your norepinephrine being reabsorbed and then increasing its signal. So when you put both atomoxetine together with oxybutynin, the adult data, the deep physiological adult data showed that it markedly increased your muscle responsiveness, which led to a reduction in obstructive sleep apnea.
And they can make a combo.
They made a combo pill, they did.
They did?
They made a combo pill, for sure. Here's just some of the trials, if any of you are interested in reading more. Some of the key papers that I've talked about today, I'm happy to send them to Dr. Danju, and he can distribute them if some of you are interested in learning some more about these. So anyway, these all show benefit of atomoxetine in adults. And so I want to show you some data in children with Down syndrome. So in this study, in children with Down syndrome, again, it was ended up being about 11 children. They undertook, and these were children, sorry, who were very resistant to therapy, but were really symptomatic. They did a PSG and looked at their quality of life at baseline. They then randomized them to what's called low dose ATO-oxy or higher dose ATO-oxy. And then after 4 weeks, did the PSG and health-related quality of life. And then after a 2-week washout, you were randomized to the other arm that you weren't in, so high dose or low dose. And the primary outcome here, again, was the reduction in OHI. And I want to emphasize that these are children who have not been responsive to other therapy, either due to intolerance or they haven't improved on other therapies such as adenotonsillectomy. I want to show here that overall, you can see that not everybody improved with their reduction in AHI, and the mean AHI was around 8, but a significant number of children did have a reduction in their OHI, and there was no difference between the low dose and the high dose ATO-oxy. And overall, when you looked at the group data, there was about a 50% reduction in OHI. And again, in that group, what they recognized is that there were some kids who were more likely to respond versus those that didn't. And Dr. Coombs, who's the author of this paper, they're conducting a much, much larger study now. Actually, it's going to wrap up at the end of May, looking at outcomes in children who received 3 months of the ATO-oxy. I think it's 3 months. And for those of you interested, that Dr. Coombs is giving a webinar. It's online at SickKids, and I believe it's July the 27th. If anybody wants to attend to hear the real updates about the benefits of this therapy in children with Down syndrome. And again, everybody's talking about this. You've probably all heard about this landmark study, but essentially using the GLP-1 agonist, there's significant reduction in weight, significant reduction in BMI, which has led to significant reductions in the OHI. We don't have similar data in children. We only have anecdotal data where children who've been on this therapy have benefited in terms of their OSA, but there isn't any really robust data out there. But I do think that as we move forward and more children are eligible for GLP-1, because right now there's pretty strict criteria. For example, you have to be pre-diabetic. But I think once that we recognize that OSA should also be an indication for GLP-1 in the context of obesity, I do believe that more children will benefit in terms of their management of obstructive sleep apnea. Okay. The last 2 slides, I don't know how I'm doing the time, but okay, I'm going to take you through 2 cases, both real cases. So patient A, this is very typical of what I will see at SickKids. So Down syndrome, she was 7 years of age, BMI was borderline, very severe OSA at 37. So in children, more than 10 per hour is severe. Lots of desaturations, with the lowest desaturation to 73%. And the main thing that mum was getting upset about how her child couldn't concentrate at school, was always irritable, was always tired. And of course, we know in children with Down syndrome, our goal is not just to treat their OSA, but across the spectrum to increase their neurocognitive abilities. And if we do that in childhood, it really benefits them in adulthood. And so we prescribed CPAP. She was completely intolerant of CPAP after 12 months. And it didn't matter what I did. We tried, I say rewards, but it was actually bribing. I tried bribing this kid. Nothing matters. I offered to buy her fluffy toys, anything. Nothing mattered. She hated the mask on her face. It made her feel very claustrophobic. And actually, we probably made things worse with trying to pursue CPAP. So there came a point where I was like, stop, just stop. Don't do any more CPAP. Right now, the impact on her quality of life is worse with us trying to deliver CPAP. And then patient B here, male 14-year-old, high BMI, also moderate to severe OSA at 21. And this kid didn't actually really complain that much. It was his mother who was complaining that, you know what, he comes back after school every day, he's sleepy, he naps 3 to 4 hours, and she felt like his grades had fallen off. She attributed a lot of that to obesity. Now, he didn't fall asleep in school. And when I asked him, like, oh, this is interesting, you're not falling asleep in school, but you're wanting these 3 to 4 hour naps. And he said, me and all my friends, we drink high energy drinks. And the current one is Ilani, in case nobody knew that that's what everybody's drinking right now. And I had no idea the amount of consumption of caffeine through coffees and all of these fancy coffee drinks and Ilani. But it's actually, that's another public health issue, but I'll leave that for now. And we gave him CPAP. He did not like CPAP, but particularly because he liked to sleep prone, so he didn't like the mask. Also, anywhere near his face, he didn't like the pressure either. So, you know, both of those, I think like 10 years ago, I'm not sure I would have had an alternative for either of these kids. And we would say, well, okay, there's nothing we can do. But right now, we recognize actually if we don't do something, that they're going to be much worse, as I mentioned, in adulthood. So we prescribed high flow, and she's one of the first kids I prescribed high flow in the home, very well tolerated. And the family actually covered that themselves. The insurance wouldn't cover it. She's still maintained on high flow in the home and has done extremely well, improvement in her symptoms and quality of life. And for the 14-year-old male, he actually quite liked the positional belt. What I can tell you, the positional belt didn't completely reduce his OHI into normal range, but he definitely had symptomatic improvement. And so our goal now, or maybe I should say my goal, is that I don't necessarily look for perfection in the reduction in AHI. I do look for improvement in oxygen saturations, but I look for improvement in symptoms and their performance during the day. So I'm going to end this there. I had given this talk, similar talk before. My title was, it's time to throw away the CPAP. What I didn't appreciate at the time, that there was ResMed, Fisher, Paykel, whole host of people in the audience. And they didn't know where I was going for this end slide. I was like, don't worry, I'm not asking anybody to throw away CPAP yet. But CPAP is definitely good for the children that are able to tolerate it, and we would continue to prescribe CPAP. But I think we also have to really think about the other therapies available, and that how we really need to target OSA management for individual children, and really still recognize one size fits all approach doesn't work beyond adenotonsillectomy. I think surgery, especially DICE, holds so much promise. And like I said, in the US, many centers now are moving to DICE as the first therapeutic option, not just straightforward adenotonsillectomy. And hopefully those results will be out soon as to the success of that approach. We definitely need more data to see who's going to benefit from those positional belts. But of course, we're excited to see, like, if we can hand out a belt that costs $150 and it can improve symptoms, then hopefully downstream it will have benefits as well. And I'm very excited about pharmacotherapeutics. And I mentioned ATO-oxy. It is not available in Canada, but we're always happy to push the envelope. My first patient is going to start the ATO-oxy as a trial. It's a child with Down syndrome, and we're going to do a PSG. Then immediately the next day, we're going to start ATO-oxy for 4 weeks, and then we're going to do a PSG at the end of the 4 weeks. But I'm excited to try it, as are the family. I'm going to end there. As I mentioned already, this is never a solo journey. I'm standing here talking, but there's a lot of people, and I mean a lot in the background, doing a lot of work, especially my research team, who are currently leading 2 very large cross-Canada studies. And of course, I'm very grateful, as always, to my funding organizations. And I just have one message to them, which is you need to increase your envelope of funding, and you need to keep funding me. Okay, I'm going to end there, and I'm happy to take any questions. Oh, there is, okay. There's some questions. Oh, you do? Okay. If you can see them, that'd be easier.
Stick in my.
So there's a question from online. It says, as children grow and airways may change or other events, do their phenotypes change over time? So I think it's, as children grow, do their phenotypes change over time?
And that's a great question. And I'm not sure we know the answer to that. We do know if you gain weight, as an example, then your phenotype will change over time. But we have a lot of children who had OSA when they're very young, when they were lean and healthy. They have a second surge in adolescence if they've gained weight. So in that way, we know the phenotypes change. But we do suspect, say, supine to non-supine sleep and ratios will change with time. So we'll probably change some of your endotype. But it's a great question.
Treating that the positional therapy will wake the patient up more frequently, because every time that they go on their supine, they wake up to turn.
Yeah, and there's adult data, right, to suggest that that's what happens. There's way more adult data than pediatric data, that as they try to move on to their side, they wake up, but also the vibrating belts, right, vibrate them, wake, so they shift position. Children arouse less, so we did not see that in children, but that is something that we will look for in the bigger randomized control trial that we are proposing in children.
Any other questions? Can I ask, you alluded to maybe trying to select those patients or kids who could benefit from positional devices. Do you use a supine to non-supine ratio in your OHI, or how would you select those patients?
Yeah, so the current Cartwright definition suggests that we should use the 2-to-1 ratio. So if you sleep basically twice the time, if you have OHI that is twice in supine to non-supine, that should be the definition of positional OSA, essentially. That is, I can tell you again, we used an adult definition. It is not the definition we should use for children. It was not predictive of who was going to respond to the belt. What we saw when we interrogated our data a little bit more, bearing in mind it was only an N of 24, is that more like 4-to-1 or 5-to-1. That's when we truly saw what we would call positional obstructive sleep apnea.
Thank you. There's a question online from Dr. Dev who says there are less expensive options than Remedy. Do you find the Remedy is superior and worth the $100 extra cost?
I don't know. Is he able to tell me what device he's talking about and how much it costs?
She didn't mention, but
Okay.
She's just saying, do you find the Remedy is a superior device? Not sure if you've compared other devices.
Yeah, the belts we've used, the Remedy or the Noodle, which is like just like a
Yep,
literally
that's
long.
the other one she mentioned just now.
Okay, the noodle. So we find the noodle displaces more than the remedy belt because you can tighten the remedy belt and it can be made to fit better than the noodle. However,